Yes, Professor Das. I'm too short for this podium to be able to see everyone, so please pardon me if I miss some cues. Dr. Tiwari and Dr. Joshi, what a privilege and pleasure to be presenting here. I'm also in the august company of several distinguished international colleagues. So thank you again for allowing me to share some important insights, I think, from our 25 years of engagement with exposure assessment studies in India. And I'm sure, I think Dr. Prabhakaran already alluded to it yesterday, that the exposure framing now has become very complex with the disruptive and interconnected environmental exposure pathways that are expected to result from climate change. But I do want to, before I scroll to the slides, Dr. Prabhakaran talked about how difficult it is to sort of, sell the respiratory health effects of air pollution to physicians. I will probably go one step further and say it is really hard to sell any risk factor to physicians because of the complexity with which these associations sort of, bear out, and the spatio-temporal delays in terms of actually manifesting, and the cost of exposure reductions often puts everybody in a very defensive way, and somehow we are not able to sort of take up many risk factors, whether it is ambient air pollution of the kinds we are familiar with, household air pollution of a kind that only low and middle income countries experience, and you can clearly recognize all these issues are going to be sort of suddenly morphing into very complex exposures that we are not going to be able to address very easily. So let me begin by posing this question: why do we actually need new paradigms for exposure assessment? Why couldn't we possibly think that some of what we were doing is actually going to provide us the answers? First, I think it is very much important to recognize that despite a very large burden attributable, some of the highest burdens attributable to environmental risk factors in India, this is the latest result from the GBD 2021 exercise, this only includes a handful of risk factors: air pollution, water and sanitation, lead, non-optimal temperature, and the pool is small. Why only such a small pool of risk factors in a developing country like ours when you should be talking about so many other exposures that are very apparent even for the casual person who's walking through our rural and urban populations? It's because of the paucity of good exposure and good exposure response estimates. It took us some 25 years to get household air pollution of this kind that does not require much science to sort of think that this ought to be a big risk factor for inflammation-mediated diseases, because it can't be, it's probably the most powerful source of incomplete combustion that everybody is sort of exposed to. And and from the time, this is a slide right out of Kheda district in Gujarat, where Professor Kirk Smith, the legendary household air pollution scientist, made these measurements, we have actually undergone a sea of evolution in the way with which Rima showed some of what can be measured now. You have wearables that can tell you everything and anything with more granularity than you can possibly think of processing. And then, we were able to actually get from exposure measurements from a few hundreds to a few thousands, to a few tens of thousands, to build the first India exposure model only in 2010 for the GBD, in a way that it would be comparable to the ambient air pollution, operating with the same counterfactual of a posterior distribution around 7.5 micrograms at that time. Now, of course, it's much lower. Rima would know this. And so the whole, that was another 10 years. And then it took us another 10 years to sort of really get to the state level exposure estimates for household and ambient, in the same breath. And I think as Dr. Das noted right on his inaugural, he noted that the burden from household air pollution is decreasing, which is good. But just look at the burden, absolute burden right now. The absolute burden is still absolutely unforgivable in terms of, we are still at a point where we are not able to think of near-term elimination of a well-recognized risk factor associated with multiple determinants of diseases and very clearly associated with poverty elimination. So you can only imagine if our estimate of, around 3 million Dalis for environmental deaths, 3 million deaths, and about, 103 million Dalis of environmental risk factors, of which nearly 40 million is counted by air pollution. How much are we missing? So, and you can't possibly wait for the next 50 years or 500 years before every single risk factor is approached one risk factor at a time. And you will all agree, I think this has been shown time and again, that the health imperative for climate extends far above air pollution, for which after nearly 20 years we have a reasonable understanding globally of why this risk factor is so important in order to be acted upon. Of course, WASH was there preceding air pollution, but you can imagine whatever we need to be looking at, heat-related illnesses, undernutrition, vector-borne diseases, worker productivity. Climate is going to be a disruptor of all of this, and we are not going to be able to adopt the same exposure assessment approaches that we have been applying to get the environmental risk factors of India on the global map. It took us a lot of effort to do that. So we need to sort of really revisit the whole thing. And most importantly, the causal webs for health impacts from climate change are going to be exceedingly complex with interplays and fractional attributions for various pathways, playing out over long time frames, probably over a single generation or even multiple generations. And clearly, Rima talked about vulnerability. I think this map says it all. India and Africa face some of the most important climate-sensitive deprivations. And these elements of multidimensional poverty are going to be interacting with any exposure, whether it's air pollution or any of the complex exposures, to play out in very, very different ways. And against this backdrop, I think if we thought that exposure assessment is a single window portal, you could go up to the counter and say, this is what I need for my population in terms of exposure distributions, we would all need multiple lifetimes to be able to sort of really answer that question. I don't think we should be looking at exposure assessment as a single window portal or even a window portal, because it is quite a bit more complex. And finally, if I haven't convinced you enough on why we need new exposure assessment paradigms, I want to allude to what Dr. Behel pointed out. You can have all the signs that you need, but you need to have good indicators that would tell you if those burdens are increasing, decreasing, if your climate actions are working, not working. And if you have a Lancet countdown indicator that has 45 different indicators, most for which we don't have actually ground level data, it is not going to be possible for us to know where we are heading. We need to prioritize with an optimal set of indicators. Top 3 climate actions. Can I have just indicators for those top 3 climate actions or top 3 air quality actions? And then we can sort of really look at how if we want to design an early warning system, if we want to design a surveillance system, where are the indicators that would work? And local context, I think we don't have to belabor this point. Anyone who visits here, even if they've never been to India, would not read rocket science to prove that this context is going to be different from any other context. The complexity, the heterogeneity, the scale, everything begs for a different approach. So I rest my case in terms of why we need new paradigms. So let me try to see, Rima mentioned this, and I'm glad she already laid out the framework, and Dr. Prabhakaran gave a very nice, elegant approach that he has already started to execute on the new paradigm. So I don't think we need to imagine it. It has already become a reality in some way. And so what is this new paradigm is what Rima and Dr. Prabhakaran already mentioned. It's the exposome framework. You can't possibly think of just the physical environment that you would want, not just the external environment. You would have to look at the rest of the environment and over a lifetime. And that's unfortunately the reality. If we sort of really have a biomedical compartmentalized model, even biomedical models, we used to be very, very holistic in our biomedical treatment approaches, and then we went into all these compartments, and now we are going back to basics again, integrating back all those compartments to look at what kind of treatment approaches would work best for the patients. It's the same deal for the exposome. And the most important, and especially for you youngsters who are sitting in the back when I trained or when many of us trained here, we didn't even know, the GWAS wasn't even a reality. We would just sort of look at single nucleotide polymorphisms at best, and then, we had to learn from our students about GWAS. And now we have EWAS, which is even more complicated. So essentially the whole thing is about, you have to look at the internal environment. You need to look at, everything that in the internal environment. Fortunately, this pointer, I'm not sure it works very well. I hope you can see the cascade, the internal environment being influenced by the external environment and leaving an imprint in your body. So you can just imagine, if you were to ask somebody where you lived, they might be able to recall. But if you were to ask somebody, when did you use insecticides in your house? And what type of insecticides did you use when you were an adolescent child? Or, how often did your dad smoke in your home? You're not going to be able to get those answers very easily. So it might be very important to see if you can find those telltale imprints that these holistic exposures would leave in your body. Wouldn't this be great? That's why it's a moonshot project. It's not going to be easy to do that. But if we are able to pick up those imprints, then we might be able to go back and say, aha, these kinds of exposures are, and that's what exposomics is all about. And a lot of times there's a lot of, as they say in Hindi, galatfehmi about exposomics. Exposomics is not exposure sciences. It is the phenomenal intersection of chemistry, biology, physics, and medicine, and physiology, where you really need to come together to sort of interpret this. So in a pragmatic way, I want to say that, how might a climate exposome try to look like? Are we really capable of doing all kinds of exposures in a resource-poor setting like us, where it took us so many years to even characterize some of the most visible and obvious exposures? I think we need to separate and compartmentalize the kinds of exposure assessment approaches that you might want to apply for, as Dr. Behel was mentioning. We have to build out the case for health effects in our context. We know some, but we quite don't know about climate change and health. We know about air pollution and health, we know about water pollution and health, we know about heat and health, do we know about climate and health? We need to build out these health effects. But then you need to prioritize how this exposomic framework that you do in a climate and health effects context plays out for prioritizing climate actions for us right here. And then ultimately, how might you sort of build out into the surveillance and early warning systems? If you may recall, Rima, this was the question on how to sort of walk across this horizontally. So let me try and see over the next 3 or 4 minutes to see how we can make some experiences that we already have for augmenting part 1 about the pillars, augmenting the evidence for health effects. Here is a European example of an early life exposome. Dr. Prabhakaran mentioned the HEALS multi-cohort pooled analysis, where they are doing exactly the same thing for an NCD exposome. So we have a diabetes exposome, we have a schizophrenia exposome, we have an urban exposome. We have many such paradigms, but essentially if you look at what the early life exposome in HEALS did, looked at multiple things that are impacting externally and integrating these exposures and looking at child health and development over a period of 5 years. And if you look at, I'm happy to share these slides. If you look at all the elements of all of this, I'm sure Dr. Das and Dr. Tiwari will all agree, every single element of this is happening in some way or the other in our ongoing cohorts, except that some are happening with greater resolution in some cohorts, some are happening with lesser resolution in other cohorts. And essentially what the Helix project in Europe detected was this clustering of the omics signatures around specific exposures and a consortium of exposures. And this is very, very powerful to sort of really look at if these omics signatures can be sort of really generalized across various mixtures that our population is exposed to. So one of the things that is missing in the global discourse of exposome studies are the rural exposomics of our populations that are experiencing exposure of a very different kind, not the kind that is the common subject of exposome studies worldwide. And so in a study that we recently completed, which was called the Household Air Pollution Intervention Network Trial, we attempted to start the beginnings of a rural exposomic framing, very similar to what Dr. Prabhakaran is already starting out to do in the multi-pooled cohort. So this was an intervention for household air pollution across 4 countries, India, Guatemala, Peru and Rwanda. That's where the study sites were, and the premise was that here's the baseline status. You would intervene with a clean fuel intervention, and together with multiple collaborators, we essentially recruited 3,200 pregnant women and followed them over a period of 18 months, and or rather 6 months of their pregnancy, 1 year of their child, and HAPPEN Wave 2 is now following up the child all the way up to 5 years. And here were the primary outcomes in our trial. And essentially the control arm did not receive the clean fuel intervention, and the intervention arm received an LPG stove and gas free of cost for a full period of 18 months. And our hypothesis now in the second phase of follow-up, do early life interventions actually result in continued growth improvements even after the intervention has stopped? Of course, we were first looking to look at whether they impacted during the trial. And the exposomic sampling framework is very similar to what Rima's pregnant cohorts are doing. You measure indoors and outdoors, filters and wearables, metals and polycyclic aromatic hydrocarbons, and then you can collect information on diet and physical activity, and we also have a huge biorepository of dry blood spots and urine, where we're looking at how the whole thing is going to play out for birth weight and child growth and development in particular. And that's the kinds of measurements that we have been sort of really doing. The HAPPEN trial protocol publications are available for you. One of the most important things we recognized was, for the first time, we were actually able to get the exposure down to under the WHO interim target guidelines, which is something that no intervention has been able to do at the household level. So this was first proof of concept that here is a scalable population level intervention that exclusive use of LPG might achieve in terms of personal exposure reductions for women, pregnant women, and for children. More importantly, we also found a positive exposure response with birth weight. This was published 2 years ago, but very, very disappointingly, the elephant in the room is the fact that we did not find a positive effect on the intention to treat analysis. An intervention that was taken up and produced health-relevant reductions for the duration of the trial did not produce the desired differences in birth weight that we were expecting to see. Especially in India, you will see we are not only statistically insignificant, there was practically no difference in the birth weight. So So again, this begs the exposomic question, are we missing something in terms, and you will see that those who received the intervention earlier in the pregnancy showed the right directionality. Maybe we were not powered, but we might not be able to undo what the lifetime of imprints that nutrition, this was a population with very low BMI, high prevalence of anemia, and that's what the rural biomass using population is. Anyway, we can discuss about it. But, what I wanted to say was, so this begs the question, and this is something that, Dr. Prabhakaran and others can shed light on. This is not a complete list of what is available. You must have already done the homework for pooling the yields cohort. But essentially here we are, but there probably is some more cohorts, from the time that the yields was funded, wherein we have a fairly, good record of information on what is available in these cohorts. Many of these study protocols as well as the primary results from these cohorts are published now, and there is an increasing population of rural-urban cohorts. It's not just our HAPPEN trial, but all our previous rural-urban cohorts. But more importantly, just look at, although we don't have omics analysis conducted, there is a possibility of actually harnessing the power of the biorepositories that are available with each one of these cohorts to really look at the omic signatures that are associated with the candida exposures, and also analyze the archived environmental samples. We have filters, we have many other curated data that can all be mined in a harmonized way if we want to sort of really pool all of this and look at creating something like this. This is a paradigm that the European cohort is, cohorts are proposing, and I was, maybe a little bit not so sad about not pooling the cohorts. Well, Dr. Prabhakaran is already doing that, but still there are many other, opportunities to actually put these cohorts together. Not too many environmental health cohorts. I'm sure Dr. Prabhakaran is struggling to sort of really add the environment to all the primary, disease-centric cohorts that were launched many years ago. But now we are trying to add environment to health. How about prospective environmental health cohorts, where we could sort of really look at what are the deficits in our life expectancy, deficits in our life potential of quality of life that we could actually correct by early life interventions. If we can look at a pooling of birth cohorts, large adult cohorts. DG was showing me yesterday results from the DAB study for biomonitoring, and what a fantastic resource for an administrative cohort where we can sort of really look at being able to longitudinally collect this data as well as go back in time. So the next thing I wanted to look at, if you want to prioritize climate action, the exposomic framework to be useful for prioritizing climate actions, household air pollution does not come to the top of mind for anybody. Right? Nobody thinks that we have to, household air pollution is an important air pollution intervention. But is household air pollution the lowest hanging fruit for climate change in India? And we think so. And that's mainly because, I won't go through the diagram, essentially not all biomass is renewed, is not harvested renewably. You don't plant back everything that you cut and you burn. So when you cut and you burn, you have, products of incomplete combustion, and, not all the carbon dioxide sequestered, so you have net climate forcing. It is no, surprise that actually biomass combustion and biomass use is, is not climate neutral. It is actually climate warming, and, it is also one of the most important sectors. This is results from Sorangsu and Sagnik's work, where black carbon emissions, just look at the big purple bar, that is black carbon emissions from the domestic sector. The biggest contribution of black carbon emissions, sectoral contributions, is coming from residential combustion of biomass use. So if we are looking at switching out, making a case for fossil fuels, and kindly remember in India, even electricity does not currently come from renewables. Even that comes mostly from fossil fuels. So if you're looking at chickening away from the case for fossil fuels for, a climate action is not just about mitigating or sort of, reducing emissions. It's also about building resilience of communities. It is also about, sustainable development, energy parity, equity, other kinds of considerations. If we want to pitch this case, wouldn't this be a low-hanging fruit for climate actions ambient air quality, I didn't show the results, I'm sure Sagnik will show these results. So how would we be set up to monitor such a transition if we are saying, bold case for fossil fuels, whether it's LPG or electricity? For cooking, electricity is still way off, but if you are saying you need to be able to prove a case that it is actually working, right? You don't have rural ambient air quality monitors, so Sagnik and I and many others are working on, validating the deployment of low-cost sensors at scale for PM. So that's one such example. And the final example is how do we sort of really link with climate and health observatories. I will not talk about all the elements of the European Climate and Health Observatory, but it's really a curation of all the information that is available out there in terms of the health evidence, the exposure evidence. It's not about mining the data. It's not like a data repository. It's a curation site where it's a single site where different partners come together, and it's a one-stop shop. Where did actions work? Where actions did not work anywhere in Europe? So it's actually a very nice pragmatic way for going forward, and and they have been able to actually do quite a bit of early warning systems for things that they have been able to mine out of the observatory. So this is just an example for heat waves as well as for an infectious disease breakout. I just want to propose that maybe we can create climate and health observatories in India. Shown on the right is the National Program for Climate Change and Human Health. We have so many missions, so much data that is being generated by each mission on something that is climate relevant. And what I wanted to propose, that we have, this is just a suggested structure, obviously. By no means these are the agencies anybody in India would be able to relate to the NCDC, ICMR, the IMD, CPCB being involved in the center. And what I would like to propose is that DG has a very ambitious plan of really creating multiple CARs in the country. Centers for Advanced Research, are not limited now to medical institutions. They are going to be in engineering institutions. They are going to be in many other, areas where we truly have the opportunity to bring together this multidisciplinary consortium, because it has to start out as an academic enterprise. It's not something that you can hand it over to the government and say, you do it, you do the observatory, because we do not have such kinds of capacities, percolating all the way up. So I want to conclude here that, Rima mentioned, I was going to show the nexus slide. We have a nexus, but we don't have a nexus presence in India. I think we should have coordinated multicentric exposomic studies for climate-sensitive health outcomes, a network of biorepositories and biomonitoring for longitudinal analysis, much bigger investments in exposure modeling. I don't know how many calls Sagnik gets every day for, generating an exposure modeling output. He must be flooded. Along with disease modeling. Disease modeling is hard enough, but exposure modeling is even harder. And launch of climate and health observatories in select states. We can't possibly do that at the national scale. Tamil Nadu and Gujarat, people in Gujarat are actually assisting the government of Tamil Nadu. Just last 2 months back, there was a major delegation from the government of Gujarat to Tamil Nadu to sort of really start this. Maybe they are good case studies. In Tamil Nadu, as I understand, may not be so bad in air quality, but it's certainly a very climate vulnerable state, as far and so is Gujarat. And making iterative local health impact assessments possible. We stop shy, we have exposures, but when you look at the health impact assessments, we immediately run into the uncertainty of the exposure response that we need to sort of really do. And the kinds of exposure response, that's why I was so delighted to see Dr. Prabhakaran, present some of the exposure response that will really answer some of these uncertainty questions. I mean, we have a long list of exposure response, but looking at it in prospective cohorts, and then finally inclusion of climate change and human health core, not just in short-term trainings, but in all MPH programs of the country, and new strategies for risk communication. So grateful acknowledgements to our international collaborators and my wonderful, happy team at Sri Ramachandra Institute of Higher Education and Research, because I think making a difference for our future should not be a matter of choice. Thank you. And I also liked somebody, I looked at student presentation this morning and said, entering into environmental epidemiology or something like that is like going to Hogwarts. You never know what the next surprise is going to be. I think that's where I want to learn from. You never know who's in. I'm not sure who the student was or the early career researcher was. I really like that. It's full of surprises, lot of unknowns, but lot of promise. So I hope this was moderately useful. There's a whole lot that's going on. I'm really old. I've been 30 years in this business. We have deployed many cohorts, many studies, but I think there is a time now to sort of reflect back on what we couldn't do in all those things and leapfrog to things that can be done in the shortest possible time using the energies that Dr. Das has assembled here in terms of these young researchers, and organizing this important meeting. Thank you again very much.